The hardest thing they can safely do, and I'm always evolving. So I used to say the hardest thing you do well. It's not a lot different than first move well, then move often. Now I prefer to say the hardest thing a person feels safe doing. So uh, the way we test is incrementally. So we identify what their goals are. If they have a hot low back and their goal is to tie their shoes and to be able to put on their socks in the morning without severe acute pain, um, then we might try in a seated position flexion, something Peter O'Sullivan shows in cognitive functional training. We might focus on their breath. We might identify that they're holding their breath, they're breathing in their shoulders. We might get them to breathe more with their lower rib cage horizontally so they're not trapped up here. And lo and behold, they might find that they have a positive experience with movement. A, they tolerate it, and B, if we audit in like a McKinsey way where we do a post intervention assessment, that now their flexion is no worse. We haven't poked the bear. Maybe, possibly even, their flexion is even better than it was before. Um, so we want to give them a positive experience with movement. We're always searching, and we link our assessments, our tests, to your question, to their story, their affordances, their action possibilities, the movements that they feel they have activity and tolerances with. So one of our first guidelines ever in 1994 from the Agency for Healthcare Policy and Research, one of the first think tanks, they said we should focus less on symptoms and more on activity and tolerances related to symptoms. So it's always person-centered. And that's the heart and soul of our tests. And then there's a second arm, there's a second track. We just look at the most basic things. I want to look at how a person's hips move. So one of the most universal ways to look at how hips moves is in jiu-jitsu, the shin box or 90-90 position. So we might explore that together. And lo and behold, a person might feel their back pain when their hips are internally rotated on one side. And they might notice that they're like the Leaning Tower of Pisa. And we can then connect the dots for them to how maybe better hip mobility can help reduce their knee problem, their ankle problem, their back problem. Similarly, we can look at simple things like a plank and see if we can get them to feel target tissue like their abdominal wall instead of feeling their back. And that could give them a positive experience with movement. And we can reassure them then through reactivation by saying this is a safe starting point. This is an exposure which you can do as a movement snack every 4 to 6 hours for like 30 seconds. And this will start to build resilience. This will create adaptations, which will buttress you and buffer you against your symptoms and prepare you for an uncertain future. So we look at their pillar, like planks. We look at glute bridges, very simple, innocent movements that are non-threatening. But even there, if something is painful, we mark it and we go, okay, that's going to be a landmark for us. We want to make that less sensitive. So hip mobility, anything that focuses on abs or glutes or hamstrings or calves or lats, tippy toe walk, calf raises, very simple, mostly body weight things are the initial screens. But then these screens, which are kind of like a warm up, these movement preps, they bleed into Glasgow's world of training, where we're now also using lighter weights and seeing perhaps what's tough at 10. Again, focusing on finding something that they feel the target tissue. So our assessment is eventually, maybe by session 2 or 3, to find things with scalable tools like kettlebells and dumbbells, where they might find that they can do 8 or 9 reps, but 15 would be too much. And it's weakness, it's not pain. So we have this sort of peeling of the onion, if for lack of a better word.